Bronchiectasis is a chronic lung disease marked by permanent abnormal dilation of the bronchi and chronic airway inflammation. While there are various etiologies of bronchiectasis, such as infection, COPD, asthma, and GERD, in many patients the etiology cannot be identified. Idiopathic bronchiectasis. Common symptoms of bronchiectasis include a chronic cough with sputum production, dyspnea, fatigue, and hemoptysis. Many patients suffer from repeated exacerbations, generally defined by an increase in daily respiratory symptoms and potential change in therapy. Increased frequency of exacerbations can be associated with disease progression and reduced quality of life. A diagnosis of bronchiectasis requires both the presence of signs and symptoms such as chronic productive cough or history of exacerbations, and radiological evidence, often via a high-resolution computed tomography scan. Bronchiectasis pathophysiology has been described in literature as a vicious cycle or vicious vortex, consisting of 4 interconnected components: abnormal mucus production and mucociliary clearance, where thick mucus becomes trapped in the airways, which renders the airway more susceptible to chronic infections. The inflammatory response is complex. It is primarily neutrophilic, but also involves a network of cytokines and other inflammatory cells, including macrophages, eosinophils, and lymphocytes. Collectively, these add to airway damage and lung destruction. Within this self-perpetuating process, each component can contribute to the worsening of the others, and thereby furthers the progression of disease over time. Neutrophilic inflammation plays an important role in the development and progression of bronchiectasis. Neutrophils are immune cells with antimicrobial properties. As neutrophils mature in the bone marrow, neutrophil serine proteases, NSPs, are activated by dipeptidyl peptidase 1, DPP1, and packaged into azurophil granules. Once matured, neutrophils enter the bloodstream, where upon stimuli, such as an infection, they are transported along a chemotactic gradient and exit the bloodstream at the site of infection. Neutrophils exert several host defense mechanisms, including antimicrobial functions such as the release of cytokines to recruit other immune cells, engulfment of microbes via phagocytosis, degranulation to release antimicrobial NSP molecules like neutrophil elastase, and formation of neutrophil extracellular traps, nets. Once neutrophils have executed their antimicrobial processes, they are eliminated via apoptosis to avoid further damage. However, in bronchiectasis, chronic infection and changes in the airway environment can lead to neutrophil dysregulation. This results in amplified numbers of neutrophils that not only survive longer, but also lead to increased NSP activity and net formation. NE activity and nets have been associated with bronchiectasis disease severity and progression. This unresolved inflammatory process contributes to tissue damage, impaired mucociliary clearance, impaired bacterial phagocytosis, and killing, resulting in airway damage. Targeting the underlying neutrophilic inflammation associated with bronchiectasis continues to be an unmet need, and a comprehensive treatment approach is desirable. Current treatment efforts are targeted towards other components of the disease, such as antibiotics to treat chronic bacterial infection, and long-term mucoactive therapies and airway clearance techniques to improve mucociliary clearance and reduce airway damage. However, individual treatments may not halt disease progression, as chronic neutrophilic inflammation and airway destruction can still be sustained by other stimuli. Therefore, a comprehensive multimodal treatment approach that addresses all 4 interrelated components of bronchiectasis may help to reduce the frequency of exacerbations in bronchiectasis patients and improve their quality of life.